I'm one of the student planners for the Mayo Clinic Healthcare Hackathon. Thank you to all the participants for pushing through this weekend. We are going to go through and introduce each of our judges and give them an opportunity to tell you who they are, and then I will go through the procedure of how you will be evaluated. So it looks like Dr. Nelson is first, so I'll let you speak first.
Hello, everyone. I'm Tim Nelson. I'm a physician scientist at Mayo Clinic and Director of Research and Innovation in Northwest Wisconsin. It's my privilege to be here as a judge. Looking forward to this event. Thanks, Morgan.
Dr. Bruce, you can go ahead next. And when you're done, you can stop sharing your camera and mic.
Hi, I'm Charles Bruce. Thanks for the invitation to be a judge. I'm the Chief Innovation Officer for Mayo Clinic in Florida and Medical Director for the Innovation Exchange.
Hi, I'm Emily Wampler. I am based in the Rochester, Minnesota campus. I'm a Senior Director of Product. I lead a couple products under Mayo Clinic platform.
Hi, everybody. My name is Edwina Baskarin. I'm the Chief Nursing Informatics Officer for Mayo Clinic. I'm happy to spend this time with you and see what you all have done.
Hi, folks. I'm Mark Weed. I'm chair of the engineering group here at Mayo Clinic. I was also a judge at the inaugural healthcare hackathon, and I'm hoping that you guys blow those first set of teams out of the water. So good luck, everybody.
Hi, everybody. Happy Sunday. I'm Melissa Zimieski. I chair the product organization within Center for Digital Health. Thrilled to be here. Thanks for including me.
Hello, good afternoon, everyone. My name is Rafael Fonseca. I'm Chief Innovation Officer at Mayo Clinic in Arizona. And as well, like my colleagues, I'm delighted to be with you here today.
Thank you to all of our judges for taking the time out to do this. I hope all of you were inspired this weekend to create some great things. We have 10 teams that are going to present. They all registered in advance, and they have 10 unique ideas. If you haven't evaluated or taken a look at the evaluation criteria throughout the weekend, there's elements of business that you'll be evaluated on. There's elements of innovation. There's elements of the impact on healthcare. So we're looking for diverse, holistic concepts that everyone can be proud of when they go home today. I wanted to explain to anyone who hadn't heard it before, we will be selecting a top 3 of these teams once all the judges have taken time to deliberate. The first place team, it's $2,500 and some time with the Office of Business Development and the Office of Entrepreneurship at Mayo. The second place team is $1,500 with time with both of those organizations as well. And the third place team is $1,000 with those opportunity to interface with those as well. We also have WeSys in the audience, and any team that presents today may qualify for their accelerator program. They will be able to talk with you following these presentations and deliberations from the judges. Okay, so a little bit of delay, and I appreciate everyone's patience. So the first team we have is Spike.io. Chaitanya, we'll make sure that you can present today, and you'll have everyone that you need to help you present, and you'll be given 5 minutes when you start. So let's see. Chaitanya, it looks like you're able to share. So if you could put cam on and mic on down at the bottom, and you'll come up to the stage here with me. We'll be having to do this.
All right, perfect.
And all right, the time starts.
Hi, everyone. My name is, can everyone hear me? Hi, everyone. My name is Dr. Mohammed Palli. I'm an endocrinologist. Here, I'm going to present our diabetes novel prevention application. Diabetes is a highly prevalent condition affecting 90 million Americans, and more than 90% do not know they have it. There is a 50% chance of progression of prediabetes to type 2 diabetes over a period of 10 years. Lifestyle interventions can be implemented to cut down this risk by 50 to 60%. Here we propose a novel CGM-based program where we're going to leverage the power of continuous glucose monitoring to deliver personalized insights to the patient to make lifelong changing behavioral modifications to help with diabetes prevention.
Perfect. So being patient-centric, we start with a user for our solution. As previously mentioned, our approach is very CGM focused. By utilizing this device, we will be able to get significant amounts of data regarding patients' glucose levels. This information will then be utilized on pre-trained machine learning models to deliver personalized insights. So it's great that we have this plan, but what is actually required of the patient? Only 14 days of rigorous data recording is actually required. Studies have shown that with just this much information, in combination with CGM data, we'll be able to provide long-term personalized recommendations. This will be delivered through various AI tools that we've built out in-house. Finally, we recognize the importance of making sure that these insights are actually being used by the patient. This will be a big emphasis throughout the development of our product. With our proposed solution, we'll be able to create a transformation like this. On the left, we show an individual with glucose level spikes throughout the week, and by monitoring these levels, they can be flattened in just the span of 2 weeks. This is actually from a small sample study that analyzed the CGM approach, and the biggest mentioned problem was the time required to personally analyze each individual. This is why our solution is effective. As we mentioned, our solution will have hardware and software components. There will be a significant emphasis on decreasing the burden on the user in terms of logging data. Existing competitors in this space require a significant amount of work from the patient. This is where we differentiate ourselves. By using not only dietary information, but also CGM data, we'll be able to provide much more personalized insights in a much shorter time period, right? 14 days of data recording. We also recognize that users don't want to spend a lot of time actually monitoring and recording their activity. So we plan on gamifying the experience to make it as enjoyable for them as possible. Finally, we recognize that we can deliver a lot of great insights or strategies, but if they aren't utilized, outcomes. Because we are using a CGM approach, by implementing these strategies, they'll get live feedback immediately in terms of improvement. This serves as a stark contrast from what most of our competitors use because they utilize lab tests and A1C tests that are more removed from the patient.
So with that, here's a demo of how our app Spike.io would theoretically work. On the main screen, we can see the individual's current blood sugar level, along with a short summary plot of the user's historical levels. We can also see self-reported activity that the user has added to the app at the bottom. Clicking on the graph, we can zoom in and notice a point of interest at this spike. By clicking on the point of interest, we can see the activities that our app has analyzed to be corresponding with this change in blood sugar. Going back to the main screen, we can also look at easy personalized strategies that our analytics recommends for the user. They can choose from recommended diets, peruse new ideas for different meals, and send activity and sugar levels to a dietitian. In addition, we can recommend alternative choices for foods that the user eats using our nutrition API.
This total number of people with prediabetes in the United States is roughly 88 million, and that number is expected to grow to 107 million by 2030. There's a limited number of modern solutions for prediabetes, with our only comparable competitor being Virta Health. This makes a massively unaddressed market with which we can make a huge impact. For example, helping just 1% of the total prediabetes population would save patients $67.2 billion in lifetime costs. Presently, we gain our data from users and give them personalized insights using our innovative method. Our target market for this phase are individuals who have family history of diabetes. They can pay a subscription and access our CGM insights, and with enough users, we gain data and capital to provide personalized prevention plans and access to dietitians and fitness instructors, allowing our users to take further charge of their own health. We plan on expanding our market to health-conscious individuals as well as partnering with other firms. This will allow us to expand into a full subscription plan and aim for performance-based reimbursement as well as another source of income. In summary, we have proven clinical experience in this problem space and have previously built algorithms and AI models that perform competitively at a national level. Mayo's assistance can help us commercialize this idea and acquire necessary data to expand our capabilities. Thank you for your time.
Thank you all for your time. You can stop presenting now, and then you can turn off your mics and cams, please, so that you'll exit the stage. Thank you. Chaitanya, all set?
Yeah, I'm set.
Yes. So to address a couple things, for excellent work to the first team, Spike.io, that was excellent. For the judges who haven't seen this before, the pitch, the development, the business plan, the code for the app, all developed over this weekend. That's kind of the idea of these hackathons if you're not familiar with them before. And you have 9 more groups that had similar constraints to go. I see I've gotten messages for a couple of judges who had trouble seeing the slides. If you're on a phone, that could be difficult. Recommend if you can get on a desktop, lighting that up. Javier, you are next. The Breathies. Do you need anybody else to help you present, Javier?
Yes, Anirudh Buriahu, please.
Okay. He is now enabled. Do you have slides to share, gentlemen?
Yes, so I will share them right now. So can you see my screen?
We can see it. It's not yet in presentation mode yet.
All right.
Now it is. So it starts when you start, okay?
Okay. So we are Team Breathies. Meet Janet. She is suffering from stress because of the several problems, like the mode of life we live, and also the problems of COVID. Like Janet, more than 40% of adults experience stress, and like 24 million has been affected by long COVID stress. So there are lots of people like Janet who are suffering stress right now. We are Team Breathies, and our solution consists on a VR headset compatible with Android and iPhone that is connected with a breathing tube through Bluetooth. So with this connection, we want to provide an experience. The user will simulate snorkeling. Why VR snorkeling? Because with experience that we are bringing to the person, we want to simulate how the person will be in the sea. It provides active engagement, deep breathing, and also visual audio clues for simulating the flora and fauna that is in the sea. How it works: the VR headset and the breathing tube is connected through a Bluetooth sensor to a mobile phone, so it can check the statistics that the person is producing with the use of the tube. So it can make some changes. Once it makes some changes. Anirudh, please.
Thank you, Javier. So compared to our competitors, Breathies offers a more personalized, immersive, visually guided, community-driven, and AI-powered solution. We are the first to market for this type of deep breathing device. Next slide. We aim to promote wellness by reducing stress, resulting in a healthier and happier population. Next slide, please. Our implementation strategy involves 3 specific focus groups: prototyping and validating our prototype. We plan to market to wellness centers, pharmacies, and medical centers, as well as digitally through social media. We aim to commercialize directly through our webpage and e-commerce platforms, as well as other strategic stakeholders. Next slide, please. We currently have sent out market surveys via anonymous Google Forms and have developed an alpha version of the app we intend to test out. Next slide. One WeBreathe device roughly costs $29 to produce and will retail for $44. We offer a subscription-based model priced at $15 per month. In comparison, one session of guided meditation class alone costs an average of $55 depending on the location. We aim to capture 0.5% of the market at the end of year 1 and 1.5% at the end of year 3. Next slide. Our team's real-world expertise in the domains of clinical medicine, public health, innovation policy, AI, and R&D and product development uniquely positions us to provide a much better solution than our competitors. Join us and breathe easy. Next slide. We at Team Breathies is a device that improves breathing and reduces stress by using an immersive VR experience. Thank you very much.
Yeah, the second slide. So I'm Dr. Shreya Sriram, and we're here for something called Aveksha for Seva. So this is a non-governmental organization registered about 2 days back. So we're trying the problem statement that we're completely back to target the biggest killer in India right now, that is ischemic heart disease. So what we do with this organization is that solve the problem statement by risk. So risk reduction strategy working as a secondary level. And we're doing this through an app. So next slide, please. So see, let's strategize the problem. Most of the risk factors that the patients come with are not treated, and so they end up with the primary event. Now it's very hard to target the primary event prevention in India. So we're targeting secondary prevention. Now, how do we do this? We first catch patients at the point of care after they've suffered a primary event, and that is we tie up with hospitals and we ask them to integrate with our app, and that's how we get data. And next, we also target the patients who are coming to our clinics. So how do we do this? By targeting the lack of infrastructure and the corruption involved with the government systems in India. So we are trying to build a smart clinic chain which integrates our app and our digital health concepts. So it solves the problem that we're facing, that is infrastructure, lack, poverty, and so it solves all the basic health problems. Next slide. So how do we monetize this, or how do we make it a self-sustaining model? One thing, we do it through donations. We are a non-profit model. So we don't take a one-time donation, sustainable. Go and ask companies to take a subscription from us and donate monthly. So yeah, that is one model. And also we attach a lab in our smart clinic, and that is how the traveling cost is covered for the patient, and we don't have to travel so far to get these investigations done, and they're more likely to pay for. And how do we do that? We give them vouchers, and we see that people below poverty line get more discount on this. And next slide. So these are the 3 business models that we're trying to. Next slide, Neha. Yeah, what is the value for innovation? I think let's look at the impact of the problem we're trying to solve here. We're being very ambitious and innovative, and I think more than how much we're trying to change, we should look at how much difference we're trying to create. Yes, it's an existing model, but our app provides telemedicine. There's a smart clinic. It solves the problem infrastructure, and you put a junior to do and then an international faculty doing the teleconsultation. So super specialists are providing care at a remote place, and it's also integrated on a mobile platform, and we're also solving medication non-adherence. How exactly do we do this? We do this by integrating missed calls sent through the app to all our patients that we track. So data collection, medication non-adherence tracking, and everything is done. How are we different from the government? We have a sophisticated system. We've already run different pilot projects. So I want you to show videos of how we tested this concept, and we're also reaching, trying to change the mentality of rural India and trying to accept, make them accept our healthcare system. This is how our app is built. Yeah, so it deals with 2 main problems: identifying patients, tracks them, and sends them reminders for medication non-adherence. And let's see how we ran our pilot projects. And in these 2 camps conducted on every month, last Sunday of every month, we saw about 350 patients, and we have recorded the entire details. So this is us going to rural India and testing whether the concept works. So next, this is the infrastructure in the slums of rural India. Yeah.
And in the background, why is it that the companies are going to donate to us? Is because we have developed training models where we go and train the employees of the companies. In India, there is something called a 2% CSR, where it is mandated by the government for every company to give back to the society. And there are few companies and hospitals who have agreed to donate 2% of their profits, part of the 2% of their profits, as a subscription for us.
Collaborating with the premier institute in India to help us give labor force in terms of doctors.
Vision Brain is a non-profit organization.
Excuse me. Okay, thank you, doctors. You can stop sharing your presentation now, please. And when you're ready, you can turn your cameras and mics off. Thank you. Good job. All right. Arch is already ready. Just a moment. You're fine. Stay up here. You're good. I wanted to remind the judges that you do have that interactive scoring system. Please ask Patrick or Young Hun if you have questions about it. You can enter your scores as you see each of the presentations, and it will update that score as we go. So you don't have to remember them all for the end. Also, if you're having troubles with your AV, please ask Young Hun or Patrick so they can help you out with that also. Archis is ahead of the game. Excellent. This is iHealth Guru. Do you need anybody else up here with you, sir, before you begin?
No, I have a great team of 7 other people, but just for organization, I'll be the one mainly presenting, and then I'll show some pictures of the team at the end.
Okay, thank you, sir. It begins when you begin.
Okay. Hello, everyone. We're Team iHealth Guru, and today we're very excited to share our functional prototype of an AI chatbot to streamline patient communication after hospital discharges. Now, I want everybody to think about the last time that you ended up in the hospital or emergency department. If you remember back then, it must be a pretty vulnerable moment in your life. And if you ask yourself, how much did you retain of what your doctor told you in terms of instructions about returning back home safely? It must be very little to none, and you're not alone. More than 1 in 4 Americans report that post-hospitalization discharge instructions are too difficult to understand. And this miscommunication between patients and providers can lead to costly mistakes and readmissions. In fact, in the elderly, 1 in 5 elderly patients are readmitted to the hospital within 30 days of discharge, which has resulted in $15 billion per year in avoidable costs to Medicare. So with this problem, the problem was clear ahead of us, and it's in a world of uncertainty and fake news. Patients need tools that can give them the answers to their questions about their post-hospital care needs fast and reliably. So in that sense, we set out to create a patient communication tool that can do just that by reinforcing discharge instructions and ultimately reducing readmission rates by improving communication workflows. Our solution is an AI chatbot to follow up with patients after their hospital stay. Here is a product overview of our functional prototype, which includes 6 core features, which we were able to complete over this weekend. These features include product features that enhance the validity of our chatbot. It's trained on a library of questions that have been vetted by the expert IT pharmacists on our team. Additionally, there are features that enhance the usability of the app, including an intuitive graphic interface that we built over our Shiny. And lastly, there are features that enhance the security of the app, such as red flag symptom reporting. If a patient interacting with our chatbot reports a red flag symptom, we've created a mechanism where that gets alerted and sent to medical teams. So in this market, what's our path in the very dense AI chatbot market towards success? Well, this weekend, we were able to achieve a minimum viable product that achieved those 6 core capabilities I mentioned. And in the next steps, we'll reach out to Mayo Clinic Ventures and perform prototype refinement, as well as steps needed to go towards Class 1 FDA approval. In the prototype I'll show you, we created a chatbot that allows patients to answer questions after they come back out of hip surgery, but we'll expand that to other markets, including after admissions for cancer diagnoses and heart disease. Additionally, we'll train our neural network on Mayo patient portal data. This is all with a target of going on the market in early 2023. This is our revenue generation model. We'll charge a baseline fee for people to access our web application on Amazon Web Services. With tiered access, larger hospitals have to pay more for a greater number of users, and we'll have additional fees related to user support. Here's how we compare an eye health guru compared to other competitors. We looked at other people in the market, including Ada Health, Healthily, Sensely, Boy Health, and we're the only solution on the market that we have the same capabilities in terms of machine learning and providing real-time answers, but we also provide that red flag alert system. And by collaborating with Mayo's patient portal system, we will have an advantage in that we can integrate with hospitals' patient portals. This is our prototype design. Over the weekend, we generated 265 lines of R code, including text mining, machine learning, and graphic user interface packages, which I'll show in just a second. Let me play this video for you. This is our chat interface. Users can put a message in the right side of the chat. That's sent into our system, and you can see the chatbot gives a response about the patient is asking about blood thinner medications. And our system is customizable to patient-specific predictors. So this is the response a patient with no AFib would get. But now let's change it to a patient with AFib. And when we see the response changes. So that's the action of the neural network that that's operating behind it. Yep.
Excuse me, don't mean to interrupt, but that is 5 minutes. It goes quick. Thank you.
Yep.
You can stop presenting and turn your camera and mic off when you're ready. He's off the stage. Excellent. Wonderful job. All right, next we have Anirudh, and the team name is Advent. Could we please have Anirudh please come to the stage? Can you start?
Yep. Thank you so much, and thank you everyone for the patience. Right, so our idea today, I'm going to quickly move on to the vision. Our idea today is that we want to confront a very fundamental question that we ask MDs, which is the amount of disproportionate reliance that we have on MD's perfection in terms of a particular treatment. And we seldom understand that MDs are in fact humans, and therefore errors are impossible. Is my slideshow moving? If not, I could probably check my slides again.
It is not moving from what we can see. Oh, there it is. It just did.
Okay. Yeah, cool. Right. So our idea is to allow MDs to embrace these errors and empower MDs to take informed treatment decisions. The way that we see that happening is through the admin system, which has three specific components, which is the improved access to adverse event reporting, treatment experience where MDs get to share their most recent experiences by treating a patient and the errors that they've done in a private manner, through which MDs can understand the information which is available to them and understand what the learnings are without any amount of liability placed on the MDs. The last one is personalized treatment feed, which provides MDs with up-to-date information on community guidelines and what are the available treatments which are there within the ecosystem. I'm going to quickly move on to adverse event reporting. Now, the current adverse event reporting system is within FDA, where FDA takes in voluntary adverse event reports that are given into the system on a day-to-day basis for product complaints, medical devices, etc. Now, what are the disadvantages of the current system? One is you have all this information available, but the FDA is not putting it to use. And this is the biggest disadvantage that we see in this adverse event system that we think that MDs can utilize in order to make their treatment decisions, right? We think that our proposed solution, which allows admin to interact directly with the FDA database in order to get real-time data out of the most recent adverse event reports, and to clean it and provide analytics on it for MDs to actually understand the incidence of an AE, also understand how AEs works by age, works by weight, works by race, etc., in order to make more informed treatment decisions. I'll quickly move on to a use case to better illustrate this. There is an MD who recently confirms diagnosis of HER2 plus HR plus breast cancer for an older patient. Now the MD is concerned because it's an older patient, therefore safety of the patient comes on top about the risk-benefit profile of two particular regimens, Herceptin or a Herceptin combination regimen with Perjeta. At this point, the MD has no particular resource that is going to compare the relative safety between the two. However, the advanced admin system takes into account the incidence of AEs between these two regions and informs the MD on which is the better alternative for them to choose from based on the AEs which have been reported so far. And therefore, the MD is now able to make an informed decision on what the AEs are, which is associated with any of these two regimens, and also would be able to proactively address any such AEs which might occur even before they do, and therefore reducing the magnitude of the consequence. Right. Now we move on quickly to treatment experience. This is where there is strong peer-to-peer learning within the community, and we would like to implement this in the Mayo Clinic ecosystem where MDs get to share their learning experiences without any liability being placed on them. Right. So there is a safe space for MDs to actually share what mistakes they've done, what learnings that they have out of a particular treatment. Right. I quickly move on to the business use cases for this. Right. So MD recently witnesses one of our patients moving on to MDC as a metastatic breast cancer on third line. They also realize that the patient now has brain mets. Now the MD is concerned about what the current treatment options are, and she wants to understand what fellow MDs have done in a similar scenario. She go on. It's very easy for her to go onto the Advent system, understand that Tukysa is a very promising regimen in terms of enhanced brain activity, and therefore she places confidence in prescribing this regimen, and therefore makes a more informed treatment decision. A more interesting business use case is where surgery is conducted. When surgery is conducted, there is a complication which develops, which the MD realizes is due to lack of communication from their end. So once the MD has communicated this through the platform, other MDs would be aware of this, and therefore they'd be able to action on these consequences even before they occur, meaning they'd be able to stay on top of communications that are given out to the patient. The personalized data feed talks about how new and updated information from different communities like ASCO.
Excuse me. Thank you. Thank you very much. That was 5 minutes. Appreciate it. Great job. You can stop presenting now. And when you're finished with that, you can turn off your cam and mic to leave the stage. Enable Dietrich to come to the stage. Hello.
Hello. Good afternoon. Thanks, Morgan.
Is it just you, or is Gabe going to join you?
No, I've got some amazing team members, but I'll just be presenting on their behalf.
Slides look like they're shared, and you are ready to go. 5 minutes starts when you start, Dietrich.
All right. Thanks, Morgan. So I work for the Department of Linen and Central Services, and our team's solution pitch is on reducing friction of customer feedback for an internal service line. So as I mentioned, I represent the Department of Linen and Central Services at Mayo Clinic in Rochester, and our identified pain point is that feedback from our users of our products and services is difficult to obtain. The feedback process is cumbersome and outdated. Essentially, it's just a link on our department's intranet homepage, and oftentimes users who experience issues may not know who we are or how to bring them to our attention. For example, to illustrate this, our linen services line distributes more than 20 million pounds of linen annually and only receives about 50 issues documented in this past year. Similarly, our central services line processes over 500,000 instruments, and only 22 issues have been documented this year. And we just know that we aren't that good. So it's usually easier to grab a new piece of linen or equipment than to report a problem. And items that don't meet expectations can easily be placed back in circulation, resulting in disappointing another customer or negatively impacting the patient experience. So we know that other industries utilize QR codes to garner quick, anonymous feedback from users at the most convenient digital touchpoint. On an upcoming slide, we'll have a QR code for you to scan, so have your phones ready, everybody. By integrating QR codes at specific points, we can allow users to scan the code and provide immediate anonymous feedback. And codes can be specific to a category or a particular piece of equipment like infusion pumps, code blue carts, or linen exchange carts on a specific unit. Data collected can be captured and reported out to work units on a dashboard. And we can also use the feedback form to educate users on next steps, like what to do with the defective linen or equipment based on their responses. So at this point, I'll invite anybody to go ahead and scan the QR code on the screen here for linen exchange cart example as we walk through the user journey. So to begin with, the user scans the QR code and has the opportunity to rate their experience as either great, okay, or poor. At this point, they can opt to decline providing additional action, upload a photo of their experience, direct message someone, or provide additional feedback. If their experience was great, those additional feedback questions are tailored to what made the experience positive. And on the flip side, if their experience was okay or poor, those questions are tailored to how the experience could be improved upon. Additional feedback questions relating to our are related to our mission, which is to provide the right product, quality, quantity, place, and time. If quality of a service is selected, users can indicate which quality criteria applied to their experience. And the user is also instructed to discard damaged linen products or asked to place them in the laundry hamper if soiled or stained. And there's also an option at the end to leave free text or contact information for further follow-up. On the back end of our system, there will be a dashboard available to view overall trends in customer responses, as well as details regarding specific contact points and a QR code and form application to manage existing contact points and create new ones. What you get out of the dashboard essentially is the ability to analyze trends in customer feedback either on a monthly basis or over a longer time period to learn more about the greatest opportunities for improvement. So the impact of this is that this process will increase patient and staff satisfaction while reducing delays of patient care by removing defective items from circulation the first time they are identified. It will also increase reports of unacceptable products and services, bringing deficiencies to the forefront so that we can focus on the greatest areas for improvement. So there are multiple opportunities to utilize this program within our own department, and we also recognize that other opportunities exist outside of our department for both staff and direct patient feedback, such as reporting restroom conditions or parking feedback. So there's truly a tremendous amount of possibilities. Ultimately, the roadmap to implementation looks something like this. It starts with developing an MVP, and then working through some of the challenges such as data privacy considerations and gaining stakeholder input. At which point we would like to conduct a pilot study using a specific point of contact such as a linen exchange cart. And after that, then we can further enhance the user experience feedback process, such as implementing additional capabilities like voice note capabilities with natural language processing. And then ultimately that resulting in the release of a beta version as a SaaS product.
Excuse me?
Yes.
That's 5 minutes. Sharp presentation. All right. When you're done, you can stop presenting and turn off your camera and mic. Thank you very much. Good job.
Okay, hi everyone. My name is Alex Swin. I'm a second-year med student here at the Medical College of Georgia. Today I'll be talking to you about the pupillary light reflex as a psychiatric point of care test. So let's talk a little bit about depression and suicide in the US. So 7.1% of all US adults have depression, and that translates to 17.3 million individuals. This percentage is actually worse in the preteen to teen population at 13.3% of all US 12 to 17-year-olds, accounting for 3.2 million individuals. So depression is, we have shown that with the advent of cognitive behavior therapy and SSRIs and the combination of both, it's highly effective at treating depression. However, the barrier seems to be getting those individuals with depression to actually get treatment. So we'll explore the possible reasons why that is. In the same realm of depression, we should also talk about suicide and suicidal ideation. So we have over 47,000 victims of suicide per year, with suicide being the second leading cause of death in the age group 10 to 34-year-olds. So this is a major issue. So here's a little bit more graphs courtesy of SAMHSA that shows you how high suicidal ideation is among U.S. adults. You can see it affects all demographics, but those in the 18 to 25-year-old age group is the most effective. You can see a similar trend in those with prior suicide attempts. So why are we missing so many cases, or what are we not doing enough to prevent suicide? So let's talk a little bit about how we assess a person, what their likelihood of suicide is. So we are using these subjective tests, patient history. A psychiatrist will use PHQ-9, PHQ-2 is the shorter version to take it. But there's a little bit of miscommunication a lot of times. Either the patient doesn't want to disclose, or they have a different perspective on their thoughts, or the patient or the physician isn't actually interpreting those questions that they are having suicidal ideation, right? So in contrast, we have objective tests. Objective tests actually give you numbers, and you can use that numbers to gauge what it means for your patient. And the best kind of objective tests are those that are point of care tests. So what we have is these point of care tests, we can take it to the bedside and actually take a measurement really quickly. So we have a glucometer, an oximeter, urine dipstick, but we have nothing in this realm of the psychiatric health. So I'd like to introduce you to pupilometry, measuring the way that a pupil constricts as a way to measure psychiatric health or mental health. So to talk about that, we need to talk about the pupillary light reflex. So we have a light emitting into the eye, and the brain interprets it, and an autonomic nervous system will constrict the pupil. And so it's shown that those with prior suicide attempts have a hyper-reflexive response, so that their pupil constricts a lot faster. So this was shown in a research by McCall et al. And so I won't lie and say that I am original in creating a device like this. It exists right now, but it's usually used for critical care cases where the patients are in an unconscious or semi-conscious state, and they determine how usually Glasgow Coma Scale, issues like that. And the research shows reflects that as well. So I wanted to introduce you to the ICU pupilometry device. So this is a 3D model of my device, and then on the bottom is my actual physical device. The inside is a lot less pretty, but it's very practical. We have an Arduino that activates LEDs, a camera that is centered on the right eye, and this is what you're going to be able to see. So don't blink, it's a bit short. So you can see that my eye constricts, and the device will record a video, and then it'll start interpolating the data. So you can see on the left the measurements. There's actually a graph of the pupil size, and on the right we have a chart that shows you the speed. So the most important is the mean constriction velocity. That really helps you determine the risk of suicide in those patients. So talking about the business opportunities with a device like this, we have 45,000 psychiatrists, 107,000 psychologists, and other realms that we can put this device in is high schools or even middle schools, any kind of those for the elderly in a elderly home, and this can help to prevent more than 47,000 deaths by suicide per year, as we have previously stated.
Alex. Okay, so what I'll ask you to do is just let me know when you want me to advance slides, but when you start talking, I will start the timer, okay?
Very good. Well,
okay.
I'm here to speak. Go ahead, Morgan. I'm here to speak about cardiovascular circulatory assist device. In particular, I picked a group of patients, hypoplastic left heart syndrome, which is next slide, which is a syndrome that affects children, and I can't read the bullet points, so I'm going to wing it here. But basically, these children are born with a cognitive disorder where the left side of the heart is atrophied. The atrial valve is sometimes not there. Sometimes it's atrophied so much that for all intent and purposes, these children are born with just a right side heart. And next slide, please. So here's an example of a child that is, and I didn't mention this because I couldn't see the slide, but the treatment for this is 3 surgeries, and the last one, they're all palliative. The second one is I'm sorry, boy, this messed me up. But the third palliative surgery is the Fontan. And what this does, and this is my son, 8-year-old Nate, excuse me. He has a condition where he has a single ventricle issue, and he has had the Fontan about 6 years out. Next slide. And some of the quality of life issues, there's certainly rhythm issues that are problematic, all sorts of different types of rhythm issues, obviously. Fontan-associated liver disease, or FALD, that is primarily caused by increased central venous pressure and other things that can occur due to turbulent flow and non-laminar flow is the increase in risk of stroke and embolism, etc. And next slide. So this gives you an idea. The top blue is the second procedure that deals with the superior vena cava, and that shunts the blood from, instead of going to the left atrium, which for all intent and purposes does not work. And if it were to remain as it was, the blood would just kind of go everywhere. So what they do, they shunt the blood into the pulmonary artery along with the inferior vena cava in the Fontan procedure, which you see here. This is really where the logjam occurs and central venous pressure is increased a lot. And next slide, please. So Fontan-associated liver disease is multiple, increase in morbidity, mortality. Some of these kids eventually wind up needing a liver transplant, which is very tenuous. So how do we deal with this issue? Next slide. So a better approach would be to have an implantable circulatory assist device that would increase the flow of blood from the venous side, relieve pressure on the central venous circulation, diminishing the risk of Fontan-associated liver disease, or FALDs, and increase quality of life and hopefully increase duration of life as well. Next slide. So the device, this cartoon, you have to bear with me, but on the top in the blue where the positive charge, with recent discoveries about the properties of water, if a tube has a hydrophilic interior and you place it in a water tank, or in this case the blood, it flows naturally. It just begins to flow endlessly with endless energy without a battery. I would also design this device with taking advantage of a relatively new discovery with this spiral flow. This spiral flow will increase inertia and momentum, and this device would be implantable. You just take a section out of a vein, replace it with this device, and voila, you've got continuous blood flow, and it's spiral and laminar in nature. Next slide. That's really all I had. The only thing I would add to this is simply that if we're able to save a liver transplant, that's about $700,000, give or take. There's over 70,000 patients who are post-Fontan, and also the possibility of a heart transplant, which is fraught with complications and availability. And a heart transplant, if it's successful, is about $1.3 million. I don't know how much it's going to cost to develop these transplants and these little medical devices that would replace parts of the vein, but I can assure you it'd be a lot less than $700,000 or $1.3 million. Thank you very much.
You're good, Eva. I'll let you start when you're ready.
Okay, great. You guys can hear me?
We can hear you.
Awesome. So our pitch is to have a patient self-monitor themselves within the Epic system to where their information is directly imported into our EHR. So we have patients that have left ventricular assist devices. Their hearts are not functioning well enough, and they need this equipment to be placed inside to them. And they have a computer on the outside that gives them parameters. Currently, right now, they have catastrophic complications that are diagnosed late because they are self-monitoring. They're using written home logs, and they're unable to take their vital signs in the normal monitoring system. There are many, many complications that occur with these patients, and they have a very high incidence rate. The cost to patients for these complications, hospital stays. The hospital stays are about $12,000 a night. So if we can keep one day out of the hospital, we're great. So currently there are existing solutions to the Lvad monitoring system. There are 3 companies that all do the same thing and are going to do the same thing that we are pitching. But the difference is that it's integrated into our EHR, and we're the ones that get the money.
Our solution is to integrate this Lvad patient monitoring form we created to the existing Mayo Clinic patient portal. This form digitalizes the process of patients recording their Lvad parameters and vital signs and enables remote monitoring of these patients. The clinicians will get alerted through the Mayo Clinic portal about any concerns that need to be addressed. Clinical providers will then give detailed advice to the patients about next steps. The advice may include things the patient can do outside of a healthcare facility, like increasing fluid intake if dehydration is causing low pump flow. If necessary, the patient may be advised to go to the hospital for further treatment or testing, or be scheduled for a clinic visit that they can schedule through the patient portal. Patients without cardiovascular expertise can benefit from this platform for medical follow-ups by experts.
So with these functionalities, our solution can cut down the medical costs greatly. So previously, it cost about $11,700 for average overnight hospital stay for a patient with complications. However, with our solution, the estimated cost per patient is around $206 per patient. And values from our solution don't end there and benefit many other end users. First and most importantly, patients don't have to come to clinics for routine monitoring and can get immediate medical attention even when they are in remote areas, which grant them with independence in self-care and decreases costly complications thanks to early detection and notification of symptoms to the healthcare providers. For clinics, our solution can be easily integrated into existing system called Epic, which is broadly used by nationwide clinics. Also, not having to use third-party platforms and reduction in rehospitalization of patients, clinics themselves can generate revenues from B2B with biotech companies and keep the medical costs down. Lastly, for biotech companies, they can appeal to the customers for being able to use the data collected from their technologies to be used in actually healthcare of the customers. Our next steps are first to connect with Mayo Ventures to set up the business and with Epic building teams to develop the platform. Then we will test the functionality within Mayo Clinic system with a small cohort of patients and take the feedback from the patients and clinicians to the build team for improvement of the platform. We'll reiterate this process for further improvements. Then we will expand by fully rolling out to Mayo Clinic system and identifying funding opportunities for further growth. Thank you all the hosts, mentors, and judges for these opportunities.
So now I'd like to invite Dr. Tim Nelson up to the stage to announce our 3 prize winners.
Good afternoon, everyone. Thank you for spending your time with us for the last 24 hours plus here. We had a delightful time looking at all of your presentations, and it's my privilege to announce the top 3 winners out of the 9 prizes that Young Hoon just talked about. So for third place, with an overall score of 2.458 on our scoring system, third place goes to Spike.io. Congratulations. And in second place, with a score of 2.635 of the overall score, second place goes to Reducing Friction. And in first place, with a score outpacing all competition at 2.844, crushing the competition, first place winner goes to iHealth Guru. Congratulations to all 3 of these top prizes for the prizes and the connections that will come with that through business development MCV at Mayo Clinic. On behalf of the judges, congratulations to everybody, and thank you for your effort that you put in. The presentations were outstanding. Thank you very much.